Leon. I got Monica Quitivo. I've got Chris Sauber. Today we're going to be discussing a case study with a 62-year-old woman with early breast cancer during the COVID-19 pandemic. So Monica, who will share her screen, I've got the article in front of me. Dr. Al does too. Interesting stuff. We wanted to talk to you guys about this because this is very relevant right now, and it will probably be so for the foreseeable future. So with that being said, Monica, welcome and take it away from here.
Okay, so sharing the screen right now. This
Uh,
is the
yeah, before you share the screen, I think let me tell you, Monica, one thing about this article. It is from New England Journal of Medicine, which is a very respectable, one of the best journals in medicine now. And it is mainly discussing a case of the patient that presented in to the to the hospital for breast cancer. And with the COVID-19 era now, there is a lot of changes that can happen and in medical practice, especially in oncology, mainly. And we see here from this there was some consensus about how to treat these patients. So the patient comes with a stage 1 or 2. In the past era where we used to have no COVID, we used to do directly surgery for them and followed by endocrine therapy or chemotherapy. It depends. And this is for the early breast cancer, HER2 negative. But now with the era of COVID, in the time of COVID, because of the risk of surgery and the risk of chemotherapy, of the patient can lower their immune system and get COVID. That's why there is now the tendency to go through neoadjuvant chemotherapy. That's mean doing chemotherapy before the surgery or doing endocrine therapy before the surgery and going from there to the other to the treatment that the patient needed. This slide mainly from the article itself. It's in the New England Journal of Medicine. I think it's the July 16, 2020, about 10 days ago, and showing for us the newly diagnosed chemotherapy. And this is the stratified the patient according to their menopausal condition. This is premenopausal, postmenopausal, and okay, and also in breast cancer we have estrogen receptor and HER2 receptors, and the treatment according to them is different in any time with COVID or without COVID. And also the triple negative breast cancer, we know that's the most aggressive type of breast cancer. Also, there is a new recommendation about treating it with in the era of COVID. And if we go over this centralized tablet that's prescribed for postmenopausal female that have hormone receptor positive and HER2 or epidermal growth factor number 2 negative, the recommendation now for early stage 1 and 2 is to do neoadjuvant. That's mean doing endocrine therapy ahead of time, and then followed by surgery and also radiation treatment for the patient. For stage 3, that means the tumor is bigger than the other 2 stages, and there's lymph node also recommended to do for neoadjuvant. For premenopausal, because the tumor is more aggressive, okay, to be considered chemotherapy in as mentioned in the slide, followed by radiation after the surgery. For the HER2 positive, because it is more aggressive type of disease, for pre and postmenopausal, they recommended doing using the special target therapy with Herceptin and Progetta with chemotherapy for these patients. For triple negative, mainly chemotherapy the only effective way to control the disease.
But doctor,
And
can this modify management during COVID-19 the pandemic put the patient at risk when it comes to the progression of the cancer?
that's the question that we find. We know that there is earlier studies for breast cancer specifically than the one we in the stage 1 and 2, that the one we did for them neoadjuvant chemotherapy, and they had complete remission, the outcome is much better. So I think this is going to be a real life trial for the patient to see, does it help unlike this? And maybe down the line we can find out if the whole standard of care is going to be changing in breast cancer for neoadjuvant or to go back to the traditional surgery followed by adjuvant chemotherapy followed by radiation. And actually, we're running now a clinical trial with Dr. Hoffman and Pfizer about using neoadjuvant chemotherapy in early breast cancer, and we're finding a lot of good response in stage 1 and 2 cancer for these patients, and downstaging stage 3 to a lower stage, but not complete response as in the other earlier 2 stages.
Okay, so yeah.
Go ahead.
No, go ahead, doctor.
No, but I'm telling you, it's a concept that's out there, and we know there is a better survival for the patient who have complete response, complete pathological response, be more accurate. That's mean after doing the neoadjuvant, they go and take the localized type of localized tumor out, and if they don't find any cancer cell there, that means the outcome for these patients is much better than the one who have residual tumor. And this is only neoadjuvant with chemotherapy or hormonal treatment is about 25 to 30% of the whole cases of the patient who receive neoadjuvant.
Okay, so which will be the key factors that you will evaluate to determine the course of action to use adjuvant or neoadjuvant therapy?
The standard of care now without COVID is any tumor have lymph node positive or tumor more than 2 centimeters. The goal of doing neoadjuvant before COVID, which is not to put the patient at higher risk of getting COVID in the normal life, like life in 2019, we used to do neoadjuvant for breast conservative reasons. That means the patient wants to keep her breast. She doesn't want to have mastectomy. She have a small, she have a tumor more than 2 centimeters, or she have a lymph node positive. We used to do the neoadjuvant chemotherapy, which is the treatment before the surgery, and then after that refer them to surgery, and then after that refer them to chemotherapy and radiation if they need it, or hormonal treatment and radiation if they need it. But now with the COVID, because of the risk of having getting the infection of COVID more, then we doing this management, which is approaching it by neoendocrine therapy, which is the least aggressive type of treatment for cancer patients. And the high preoperative mortality for the patient and elective surgery for breast cancer, that's what drove us to go through this kind of approaches for these patients, where we're trying to conserve the resources to give it to patients who need it, who are much more sicker, and trying to control and limit the viral spread and minimize the surgical risk for these patients. And we know that the patient, if you go through surgery in the COVID time, now they had about, especially if they have diagnosis of cancer, the 30-day mortality for them is about 24% comparing to the, yep. So that's why we're trying to do these kind of things, which is trying to reduce the risk of patient getting the infection and dying because of that.
So do you see this modified management during the COVID pandemic as an opportunity to do research to compare the results, I mean, of the previous results using the regular treatment against the the new treatment that is being treatment that is now using that is being used now during the pandemic?
I think it is. I did not find any research study now running to compare the modified management for the patient who have a breast cancer at this time. There is no. I don't think there is any clinical trial that do this now at this time because of the seriousness of the illness itself. It's not a time to put patient life at risk because of the clinical trial. So I think at the end of the day, because we have a lot of data that compares the COVID for the non-COVID trial before, and most probably they're going to do kind of collection of information or after the COVID or after they try to control the COVID to do these kind of information. But I think it's worth to go this because there is a lot, especially in oncology, because there is a lot of changes in practicing oncology these days because of the COVID.
So, if I can interject one question real quick, what's your personal opinion, Dr. Al, in terms of the modified therapy versus the previous therapy? Do you think modified therapy puts patients at greater risk?
I think my personal opinion depends on the patient, because I think the first thing have to be to do is the safety and safety of the patient. So I should not, if any decision I want to make, I should not sacrifice the outcome of the treatment for the patient. Okay, and the American Society of Clinical Oncology, the ASCO now, is bringing out more recommendation, not only for breast cancer, but for different cancer. And I have to follow these things. I don't think I will do a judgment on myself for these patients to treat them and jeopardize the outcome because I think it is better. I think I should follow the recommendation as we've been doing, following the guideline all the time for this type of treatment for the patient.
Okay. Thank you.
No problem.
And I was reading also in the article about the ultra hypofraction regimen that we were discussing.
The hyperfractionated radiation therapy, I think it is troublesome for the patient because they have to go more than one time at the same day for the radiation center, but also it is less time consuming for the patient, and the outcome of the hyperfractionated is better than the conventional radiation treatment. And I think with this, I think hyperfractionated should be adapted more at this time. It's at this time of COVID pandemic for the patient. It's an excellent question, Monica.
Thank you, doctor. Well, this seems to be.
I think we can go to the other slide now,
Sure.
Monica, which is talking about the new finding of COVID-19 with the.
Yeah, I'm gonna share it in a second.
Anyway, this is like how to, for the physician in general, how to make their, in oncology, how to help them in making decisions regarding the patient. This is why we go back for your question, Chris. Would this change my practice of medicine? Yes, 100% will change my practice of oncology. And these tools or these things is to help us in making the right decision for the patient as we can. And this is, if you find the decision regarding immediate cancer treatment during the COVID-19 crisis, and on the side, risk progression with delay of cancer treatment, and on the top right side, risk of significant morbidity. Okay, these kind of tools will help us in making the right decision for the patient. And you see, there is from the study and from the information we have about cancer in general, they specify the patient for low, intermediate, and high risk. And they put the recommendation as thumb up or thumb down for the patient, what to do for them to try. So they're saying for low risk, for low risk patient who have no melanoma, hormone positive breast cancer, and low prostate cancer, type 1 intermediate endometrial cancer, and age, at any age, delaying the treatment for more than 3 months, it will not going to affect on the expectancy of the patient life. But if you look at the high risk patient, which is the one who have colon cancer that's obstructed, or tumor that's more than 2 centimeters in the lung, or pancreatic cancer, or hematological malignancy, or they need radiation for certain type of cancer. The main thing is like to do the treatment for them ASAP. For patient whose age is less than 70, for the patient whose age more than 70, it depends on the physician call himself, how risky, how dangerous it is for the patient. Because the patient who their age more than 70, they have higher risk of getting infection and complication.
So if I can ask, because I've always thought that pancreatic cancer, being one of the cancers that are in high risk, I always thought that was terminal. I thought there was no, like 6 months, is what I've been told by other oncologists. Is that not the case?
It depends on the case. It depends on the stage. For early breast cancer, now we can do chemo and radiation, which can improve the progression, and after that do for them the surgery. For other type of pancreatic cancer, we can do surgery followed by chemo or chemo and radiation. And pancreatic cancer is different type. The one you're talking about is metastatic and adenocarcinoma, which is the most aggressive neuroendocrine tumor of the pancreatic cancer. It behaves completely different from the adenocarcinoma and can be controlled with other. We have target therapy now for pancreatic cancer, which can help in improving the survival and reducing the symptoms that can come with pancreatic cancer.
I was just thinking there's really no point in even doing treatment if you're terminal, right? I mean, at best you prolong your life.
We changing our perspective about this these days in cancer, pancreatic cancer patients, because we have much more type of treatment and much easier side effects.
Yeah. Okay. Sorry, Monica.
No. And how about the patients that are phase 4?
Yeah, that's why we're talking stage 4 cancer. It depends on their complication, and if there is some kind of stage 4 cancer that we improve their quality of life by oral pills itself only. We don't have to go through chemotherapy for them. Breast cancer hormonal treatment can be helpful. Other target therapy, that if we can do new genomic studies or genome study for the cancer and find out the specific target therapy that can be effective, especially if it is oral, can help. In the COVID era, they're trying to discourage using the immunotherapy because it can work on reducing the immune as same as chemotherapy.
Now, with the HER2 receptor for breast cancer, The HER2 negative is most common, or which one is the most common?
The most common is the HER2 negative. About 20% of the breast cancer is HER2 new positive.
So HER2 negative is the most common. Okay.
Yep.
Because on this chart I don't see HER2 positive.
I think this chart was for decision making in general, but the chart that you saw before,
Okay.
that they were talking specifically about HER2 new, but this is in management of breast cancer
Okay.
in general.
Okay. And that's
I
also
think
one of the
that
reasons why the triple negative is the most
Aggressive and
aggressive.
need
Yeah.
to be treated by chemotherapy.
Right. Okay. That makes sense.
I think all this new, it's just opportunities to do more research and to compare, to consider more like in between the treatments that were the normal with the new ones. And I think it's going to improve a lot how doctors and, not just not just for cancer, but in general, for new approaches, it's open up more opportunities and probably opportunities to do more research too.
I think you're absolutely right. This is where you doing that. You're saying that the bottom line of the whole thing here, Monica, it's an opportunity of doing more research and more because of the changes of the practice, and we need to compare it to the standard of care that we used to do before. These are new things, just recommendation, and the physician judgment come at the end what to do or what not to do and how we can approach these patients. But is it going to be the standard of care? We do not know. But if we can have another pandemic or anything, at least we have a guideline to proceed with as if we did the clinical trial.
So as long as the disease is stable in the neoadjuvant setting, you can delay therapy for 6 months or delay the surgery for up to 6 months using the neoadjuvant therapy.
Yes, especially if it is hormonal treatment, you can delay the treatment in early breast cancer, what you're talking about. And different type of other cancer, it depends on the stage and with the aggressiveness of the disease and the presentation also.
Mm-hmm.
In general, the patient who have COVID-19, they are typically they have more chances to die because of the infection. Having cancer on top of it, that will increase your risk. Most of the patients that have cancer and possible infection with COVID, they present with the symptoms of like cough in general and
Yeah.
fevers, sometimes anemia or sometimes lymphopenia. Patients who have cancer and COVID, 50% of them will have a severe course. About 21, 25% will go to the ICU of
Mm-hmm.
them. This is I'm just giving you an idea about the risk of why we should look into these kind of things as physician and try to guide ourselves, because the outcome of these patients, if we're going to put them through major treatment, it can be really bad for them. A factor that can be associated with 30-day mortality more is older age, mainly for these patients, male, smoking, lung cancer, and increase in the comorbid condition like diabetes, hypertension, coronary artery disease. Having hematological malignancy is worse than having non-hematological malignancy, and the risk of dying with hematological malignancy is fourfold more than non-hematological malignancy.
So the rationale because when they're taking neoadjuvant, let's go back to breast cancer, and then I want to ask you about what you're doing with your current treatment for outpatient as well as the clinical trials that you have during a pandemic, because you're still, there's still a risk with these patients coming into an office when they have possibly low white blood cell count, right? Neutropenia, it's a very common side effect of the treatment. So there's still a risk for the patients even to come into the office, right? Like even beyond surgery, just coming in, getting the chemo treatment or getting the treatments. What's the rationale for postponing the surgery other than the hospital resources maybe not being there? Is it the infections, the rates of infection can go up because of neutropenia if they receive neoadjuvant therapy, or is that not the concern?
In general, the chemotherapy is more aggressive treatment considered for the patient than hormonal treatment. And in general, any type of treatment can affect the immune system, can increase the risk of having COVID-19. Going out of the office, out of the house, coming to the office more frequent as before, it's one of the things that can increase your risk of having or contracting the COVID-19 or the viral infection. There is a lot of tendency now to do treatment at home for the patient or trying to do for them less office visits and more telemedicine where they can interview the patient over the phone to see the side effects. The patient who needs to be treated need to be treated. Triple negative disease, HER2 positive disease need to be treated. Will we change our follow-up, maybe less frequent visits, maybe sending him nurse to the home to do his blood drawing and do stuff like this will be easier for the patient and less risky for him.
Mm-hmm. And has your office, your private practice, and the outpatient research studies that you have in your office, has that changed at all with COVID-19, or is it still the same procedures basically for the patients?
No, it is much more change than before. It's not just change because I'm trying to reduce the average visit for most of the patients who is only for surveillance or they finish their chemo. Do for them more frequent call and like this. For the chemo patient who's been getting it in my office, I've been trying to do for them a conference call after the chemo day and even in more frequent, try to manage their side effects over the phone,
Mm-hmm.
try to send them home health and like this. So
Mm-hmm.
the scope of the practice completely changed and like this. My office, as you used to come and see it, so busy now, I see much less patient in my office,
Right,
trying to reduce the contact of the patient with
right.
a healthcare worker, try to reduce the contact of the patient with other patient when they come into the building or into the office, and try to reduce the risk of make their condition more complicated.
So basically, they're still coming in to get their treatment cycles, but all the follow-ups that would have been done in person are now being done remotely, virtually, or sending someone to the home.
Exactly, and doing more assessment for them. If they need to come, we bring them and need to be hospitalized. We still hospitalize them, but trying to keep the hospital bed mainly for sicker patients who have the virus infection.
Okay. And
Okay.
as far as research, nothing has changed really. That I know from the protocols we're
Actually,
doing, the protocols haven't really changed, but they're allowing more of a remote visits if need be, for the ones taking I mean, let's say it's not an infusion, it's an oral treatment. They can take it from home instead of coming into the office and things like that.
I think you're absolutely right. And there is a new recommendation by FDA, according to the CDC, and also from the European societies about how to do trials in the COVID-19. Maybe we can discuss it next time to go over the FDA recommendation and see how it's going to change our landscape for trial as we change the COVID-19, change our landscape for treating and following up with the patients.
Okay.
I think this COVID-19 kind of shaking everything, but I mean, obviously, all changes are some difficult, and but this is giving us a broad perspective of treatments are more um, like open the mind for everybody to take a look beyond that what we have that we had in the past. And I mean, it's again, like I mentioned before, I think it's a great opportunity, especially for new treatments.
I agree with you 100%, Monica.
Yep.
Any more questions, guys? Chris, Dan.
I have no more questions. Very, very educational, though.
Yes.
I know it's too much like concentrated regarding oncology and like this, and there is a lot of oncology jargon there. But I'm trying to make it as simple as I can, so everybody can benefit from these
Mhm.
kind of podcasts, and everybody can. But if any question need to be done, just let us know, guys. We're more than helpful. And maybe,
Yeah.
as I told you, Dan, next week we start talking about the FDA recommendation about the clinical trial in the COVID era.
Yeah, we can do that because that, one of Monica's questions early on was about, is this the ideal situation to do a study on this, on postponing the surgery in breast cancer, for example. And you were saying that that's probably not the best idea because you don't want to do a study and put patients in unnecessary risk. But would it be appropriate to do a study like this during coronavirus outbreak, right? Where that basically is the standard procedure. So I don't know. It's a lot of complicated questions here.
But we can use the data for future reference at least.
Yeah,
I,
you can
I,
do, I
I,
guess, retrospective studies where you look at the charts a year from now for the doctors that are following these recommendations of delaying 3 months, 6 months if it's safe to delay, and then we could look at progression of disease a year from now, just doing the charts and seeing like a retrospective review rather than doing it in person just because the patient, just because we need to do a study. So maybe that would be the appropriate. That's a sneak peek for next week. Sneak
I
peek
think so.
for you clinicians who are primarily watching, and everyone else, just like me, Monica, and Chris. There's a lot of people like us watching that are interested in this. And, we're always about clinical research, making it practical to do studies. There are tons of cancer studies right now on clinicaltrials.gov. So if you're interested, if you're an oncologist interested in doing one of these cancer studies, reach out to one of us, okay? And, Dr. Al, myself, Chris, Monica, reach out. We can probably have a conversation about what it would take for you to get started doing clinical research.
Yeah, and we probably can also share Dr. Al article and all the information that was given here.
I have one
And
copy autographed by Dr. Al, so I'm giving it.
It's not my article. I just was one of the journals that I received, and I was reviewing it, and I found it is interesting to discuss because it's gonna change
No,
the
it's
scope of the
interesting.
practice in oncology.
It's very interesting, actually. And
yeah, it's
seriously,
really, really interesting.
anybody that watched till the end, the first person that emails me, Dan at theclinicaltrialsguru.com, I will bring this paper back to Dr. Al, have him autograph it, and we'll mail it to you.
You funny guy.
We'll do it. Try me out, guys. If you stayed 40 minutes, I know you're passionate about this, so you deserve something.
That's a great gift.
I think so. If nobody wants it, I'll keep it.
Me too. Actually, when I bring mine.
Well, that was a good episode, guys, and a good cliffhanger for next week. So thank you, Dr. Al. Thank you, Monica. Thank you, Chris. Thank you,
Thank you,
everyone, for
guys.
watching and
Thank you,
listening. And
Dan.
we look forward to doing this every week with you guys. Take care.
Thank you,
Thank you.
everybody.